psychiatry, and we try to have these meetings quite regularly. And today we have some unique sort of a topic which we are supposed to discuss about the biological perspective of history taking. I think we have two very capable people who are actually deliberating on this, and we have Dr. Bhaskar Mukherjee, who hardly needs any introduction as far as biological psychiatry is concerned. He actually is against the idea of saying biological psychiatry. He says that psychiatry as such is biological, so why to have a
Yes.
biological psychiatry? And we have a very well-known psychiatrist, psychotherapist, a counselor, and more importantly, a leader in psychiatry who almost is every day busy with one or other events, which I like most. That is community outreach. That is how we can remove the stigma, how we can make people aware and educate people. Uh, with this, I think Avinash Desousa is with us. He is one of the wonderful speakers I have come across in my lifetime, in my experience as a psychiatrist. He's a consultant psychiatrist. He's a founder trustee of Desousa Foundation, which works for in the area of mental health awareness. As I said earlier, he's an associate professor, International Institute of Organizational Psychological Medicine. He has over 600 publications in national and international journals, and you can see that the research interest he has. One of the few psychiatrists who, in
I'm
addition to
sorry, but the Zoom meeting is getting muted, so I'm not able to hear Majid. I
oh,
mean, but that's okay. I mean, I don't know why, whatever is. Mm,
but I think
your
everybody else is listening to me.
Are
I
the others
Yes,
able to
yes,
hear the others? I'm the only one
yes,
not.
yes, yes.
Okay,
Your
yeah. Yeah.
your end
Yeah.
is getting some
yeah.
Yeah.
problem.
Okay. Okay.
Okay. So, in addition to psychiatry degree, he has masters in counseling and psychotherapy. He is MPhil in applied psychology, and he has MBA in human resources development. He has been awarded a doctorate in clinical psychology from University of Hertfordshire, UK, in year 2011. So, this is Dr. Avinash D'Souza for you. Avinash, you can go ahead, and I think it
Yes.
is all
Yes.
yours. Please proceed.
Yes. I think good evening, everyone, and we're here today to attend to a very important topic. I don't think the topic needs to be discussed further. We have a great speaker who's going to talk about it. I'll introduce our moderators and facilitators for today. Our facilitator is Dr. Susmita Sarkar, who's a consultant psychiatrist at the S.M.S. hospital. She's also done a course in computational psychiatry and computational neuroscience, and that's why this topic, she's the right facilitator. Our moderator for today is Dr. Bhaskar Mukherjee, and Dr. Bhaskar is, of course, a consultant psychiatrist at the Aurobindo, Seva, Kendra, and ILS hospitals, Kolkata. More importantly, his areas of interest are transdiagnostic psychiatry and well, apart from that, most importantly, he's one of our go-to persons whenever we are stuck with any concept in biological psychiatry. And though he may not like me saying biological psychiatry, but still. And the thing is, most importantly, he believes that his goal is to bring psychiatry back to its star spot as a medical specialty and not just as what psychiatry is looked upon as today. So I will hand over to Susmita and Bhaskar to introduce our speaker and take the session ahead.
Hmm. Hello, everyone. Slight correction. Actually, our speaker has our speaker is Dr. Divya Sharma, and she actually has degree in computational neuroscience, and she is an assistant professor in S.M.S. Medical College. Our facilitator is Dr. Susmita Sarkar, who is still muted and still not visible. I don't know why, but she is at present a senior resident in Damnabar Government Medical College of West Bengal, as well as she is doing her humanitarian work in a nearby hospital known as Antara Psychiatric Hospital, and as well as she is interested in transdiagnostic psychiatry and neuromodulation. So these two are actually speakers of today, and my job is just to be present here and try to look good, which I cannot do because I am a very bad looking person. So the stage is all yours, ladies. Best of luck.
Thank you, sir. A very good evening to one and all. I'm going to share the screen now. So the topic is the examination from the biological point of view. We'll first start with the physical examination. Physical examination, as it helps in assessing the brain status and gauge the extent of the damage. Also, as per current understanding of psychiatric illness, we consider that psychiatric illnesses are behavioral manifestation of brain dysfunction of a systemic illness. So we should not miss out the systemic examination, which includes general appearance, head, hair, and facial examination, eyes, oral mucosa, neck, chest, abdomen, extremities, lymph node, and skin. We have neurocutaneous markers which can be present and like of tuberculosis and neurofibromatosis, which should be observed. Next is the head examination. In case of an infant or a child, the head examination is one of the most important markers for a dysmorphism, along with other which will be discussed in detail. So we have to see the head for the size, shape, symmetry with the fontanelles, and how is the size of the circumference and everything, along with the height velocity and the growth velocity. Now the Susmita will take over the stage for the neurocutaneous marker.
Good evening, everyone. So I'll continue from that. So what Dr. Divya is telling that for physical examination, we have to basically examine the head-to-toe examination of the patient is required. So there are two things are important in this aspect. One is neurological soft sign and another is minor physical anomaly. So coming to neurological soft sign, what is it? The neurological soft sign comprises the subtle deficits in the sensory integration, motor coordination, and in the sequencing of motor acts, which are there are studies where we have seen that majority of patients of schizophrenia, even treatment naive patients are having this. And then after the completion of treatment also, and even we can see the first generation relatives, they are also having this. So for neurological soft sign, there are different scales. Uh, as in the previous scale, it was Mehes scale. That was the first scale that was used to actually see the patient's children of hyperactivity. So these scales, it may appear like it's a very big list. How I can apply in this in this short duration time, it's like it's just a matter of practice. If you start seeing the patient when patient enters your OPD room or whatever, then if we start observing it every patient, then along with the physical examination, we will see these things. So if it had a diagnostic value, no, it doesn't have a diagnostic value, because there are the neurological soft sign and minor physical anomalies. They are actually these are the signs of brain morphogenesis defect. So brain origins from the ectodermal origin, and any other thing that are ectodermal origin, that is going to affect it there. And in patient of psychiatric disorder will have it more than general population. That's it. And if we start seeing systematically from head to toe in neurological soft sign and minor physical anomaly, the chart I have shown in that, the minor malformation, phylogenetic variants and all this, then it will be easy for us to see.
Thank you, Susmita. Now we'll talk about consciousness. The initial step in administering a formal examination is to determine the patient's level of consciousness. The consciousness is defined as the state of waking, with subject being aware of the self and the environment, and any disturbance of this elementary function almost invariably affect others. So the disturbance of consciousness can occur due to loss of excitatory postsynaptic potential, which may be due to ischemia, hemorrhage, or the cerebral herniation, or there's an excessive discharge or hyperexcitability, which is due to epilepsy. Also, when we see patients of episodes of unresponsiveness, we should always keep in mind that the transient loss of consciousness can happen in epilepsy and in syncope. So there are few examples of those syncopes like cardiac syncope, orthostatic hypotension, vasovagal syncope, which we should keep in mind while assessing a patient. And the disturbance of consciousness can be classified into two types. That is, one is a decrease in the level of consciousness, which is called the clouding, which is further divided into somnolence, stupor, semicoma, and coma, and a language of behavioral abnormality, which is the alteration of consciousness, which is the examples are delirium and encephalopathy. So after determining the level of consciousness, assessment of attention is the next step in the examination. The inattentive and distractible patient cannot efficiently assimilate the information being presented to the patient. So the attention has to be tested. And in this, the first test will be the digit repetition, which is the basic test of attention, where we'll ask the patient to listen to the randomly presented number without natural sequence. And we have to begin with the 2-number sequence and continue till the patient fails to repeat all the number correctly. A patient of average intelligence can accurately repeat 5 to 7 digits. Then there's a sustained attention where a random letter test, which consists of a series of random letter, is given to patient where a target letter appears with greater than random frequency. The errors here in this are omission, where he misses it out, commission when a letter is not there, but he still commits, and perseveration. Then there's unilateral attention, for which we should check the patient. Here we give the double simultaneous stimulation on the same body part. And before undertaking this, we should know that his sensory modality should be intact. Next, the language. The language is a basic tool of communication and one of the most influential brain model of speech and language organization emphasize on the connections between cortical region. So earlier we had a model which had talked about only fixed areas of the brain. Now they're talking more about networks and hub. So now we have to assess the spontaneous speech and the verbal fluency, comprehension, like is the speech output present, is the speech dysarthric or dysprotosic, or is the evidence of specific aphasic errors is there. Then we should assess for the repetition, naming, writing, spelling, and other things. And these are the test items from simpler to complex thing we should be given. And we should remember the articulation disturbances like dysarthria. It raises the suspicion of the motor neuron disorder and Parkinson's. And next is the aphasia. So language function impairment is aphasia. So aphasia can involve difficult degrees of impairment to multiple speech and language processes. Here it's one of the diagrams where they show multiple areas which are connected to form a network for the language production. Next is the critique of the classical model, because earlier the classical model fixed the areas like Broca's Wernicke's and the arcuate fasciculus for repetition. So we see the critique was that it is a purely cortical model and there's a delimitations of it misses out the important nuclei and it excludes the relationship with other functions, and the clinical signs falling outside the diagnostic categories are also missed here. Right. So now when we are assessing the networks and hubs, we should assess the patient for the apraxia, agnosia, and visual spatial agnosia. So praxis also should be assessed, which is the ability to perform skilled or learned movements. So the patient is unable to perform a motor task when his motor and sensory components are intact and find it difficult to use given tool in an adequate manner and in a sequential form. It is a apraxia. And the agnosia, like patient can hear a sound but cannot tell what the sound is, like it's an auditory agnosia. In the visual spatial agnosia, we will see like the patient is unable to count the numbers of the visual target presented simultaneously, like agnosia of the optic counting, to read a clock, which is agnosia of clock reading, and to distinguish between near and far, which is the agnosia of distance. Next is memory. So memory, we have to assess like immediate recall, short-term memory, which is the digit repetition, and the verbal story for immediate recall, where we give a patient a story and ask questions from it. The orientation, which is like place, time, person, and all those in the recent memory. Remote memory, any event from the past, a significant event from the past has to be assessed. The new learning ability also should be assessed, which is 4 unrelated words has to be given, and after some time, the patient has to be asked about them. Also, the verbal story for immediate recall serves as one of the tests for new learning ability. The visual memory for hidden objects, we have to hide objects in front of the patient and ask them like where the objects are hidden after some time. And there's paired associated learning. Here, the pairs of things are given to the patient when one pair is presented for per 2 seconds. And after the first word is given, the patient is allowed 5 seconds for the response. So also sometimes some people do the 100 minus 7 calculations for memory, but we have to remember that doing calculation, like a patient can have acalculia, which is can happen due to the lesion of left supramarginal gyrus, like it's a component of Gerstmann syndrome. And along with that, we should also assess the patient for right-left disorientation, alternating motor pattern test, fist palm side test, conflicting instructions, and go-no-go test. Those like usually they are considered of the frontal lobe test, but they are more about the inhibitory pathway functioning, and it is like impaired somewhat in the patients of impulsivity. Now we go on to the nerves, like olfactory nerve. Before starting, I would like to tell that olfactory and the optic nerves are the two nerves which are from the secondary neuron of the sensory system, and the myelin sheath is formed by the cell membrane of oligodendria, even though their fibers are situated outside of the brain. So, while evaluating the olfactory nerve, we have to keep the eyes closed, occlude one nostril and test other, and we have to compare the two sides. Second, optic nerve. We have to check for the visual acuity, where we have to hold the card at comfortable reading distance and cover one eye at a time. And if the patient has glasses, we have to ask them to keep it on. Visual field has to be tested, fundoscopy has to be done, and the afferent limb of the pupillary function is served by the optic nerve. And because it is a nerve which is coming from the, it's oligodendria is the sheath, so it is affected in the multiple sclerosis. The pupillary function, which is the afferent is the second nerve and third is the efferent. Here the normal pupils are equal in size and are situated in the center of iris. And when there's a variation, like less than 2 is miosis, mydriasis more than 5, and when the asymmetry is there, and anisocoria. The light reflexes, where we fix the gaze on the opposite wall and shine bright light obliquely into each pupil. The accommodation reflex, it's like hold fingers approximately 10 centimeter from the patient's nose. This is about the gaze and saccades, like how multiple areas are involved to cause the smooth functioning of the eye movements. The third, fourth, and fifth nerve, for their examination, we have to see the visual inspection, that ocular alignment, lids, the conversion, the smooth pursuits, is there any saccades and nystagmus, and all the 6 direction of the gaze has to be assessed. Like movements are complete by the a 4th month of age. So before that, we cannot check for that in a kid. And acoustically illicit eye movements appear at 5 months of age. We should also look for ptosis, diplopia, head tilt, doll's eye movement, and the depth perception usually comes by 2 years of age. The trigeminal nerve. For the trigeminal nerve, we have to assess for the corneal reflex, the masseter strength, and jaw jerk. Here we should also remember that the patients of ALS who have also the bulbar and pseudobulbar palsy together, they have muscle atrophy in the tongue, yet the jaw jerk is hyperactive. The 7th cranial nerve, we have to assess for the McCarthy reflex, palpebral reflex, and the sensory anterior 2/3 of the tongue. This is the 8th nerve. Here, hearing. For that, we can rub finger rubbing like at an arm's length. And if the patient cannot hear the strong rubbing, then we have. It is like we consider the hearing is impaired. The tuning fork test can be done Weber's and Rennie, though they are considered they have a poor sensitivity. Cochlear part, for that, the Morose reflex in the child can be done. And later they can have the Rennie's and Weber. The 9th and 10th, for that we can test centers on motor function, which is palate elevation, swallowing, voice, cough, gag reflex. And also we can check here for the phonation, because sometimes in the spasmodic dysphonia, there is which is autosomal dominant disorder, there is a spasm which can cause a dysphonia. Also, because the 10th nerve has a important component in the parasympathetic efferent system, so we should assess for the autonomic nervous system. And also multiple psychiatric illness is considered to have dysautonomia, which we don't pick it up. So we should assess for the supine erect heart rate, Valsalva's ratio, and pupillary response to light. All these things should be assessed. And like about the sympathetic skin responses, thermoregulatory sweat test should also be done. Also, like there's a disorder where the Casper-2, which is like a voltage-gated potassium channel antibody is there, where the patient has a Morvan syndrome, where he has neuromyotonia along with the ANS dysfunction and hallucinations and severe insomnia. So the motor examination, we have to compare left to right, proximal to distal, and we have to compare to see the bulk, tone, and test the passive manipulation, the strength, speed of movement, extraneous movement, and endurance. So we have to remember that rigidity is enforced by the emotional stress and cognitive task. And there's a myotonia, which is like a increased muscle tone, and where the patient is not able to relax even when the examiners tell him, and it is due to the disconnection, functional disconnection between the basal ganglia and higher cortical centers. Okay, so the muscle strength testing is more sensitive to lower motor neuron dysfunction, while test of dexterity and coordination is more sensitive to upper motor neuron dysfunction. We have to isolate the muscle, fix proximal joint while testing, and always give ourselves the advantage. And then there is normal variability with age, sex, muscle, and handedness. Also, when we are doing the motor function test, we have to look for the extrapyramidal features, which suggest the Parkinson's disease or extra Parkinson's disease like fasciculations, myoclonus, chorea. This all should be kept in mind while doing the examination. These are the DTR which we should check for the patient. And the superficial reflex plantar. In this, the Babinski, normal response is flexion, where the toes go down, and the abnormal response is extension, where the dorsiflexion of great toe as the extensor hallucis longus is recruited. It is a sign of hyperexcitability associated with the corticospinal dysfunction. Sensory examination. The patient, each test, before we do it, we have to explain the patient, and you have to, his eyes should be, or his or her eyes should be closed, and all the 4 extremities has to be tested. We have to avoid the leading questions and compare side to side or distal to proximal. And when we detect an area of sensory loss, we have to map out its boundary. Also, the primary sensations should be tested first, like pain, temperature, light, touch, pressure, vibration, proprioception. The integrated sensation, which is graphesthesia, stereognosis, and double simultaneous stimulation should be tested next. Then the Romberg's, which is a sign of equilibrium, like it tests our dorsal column along with the vestibular component, and cerebellum should be done. And the coordination like heel shin test, finger nose test should be done here. The gait. Now the gait is not just because of one thing, it is multiple components of brain are involved to have a smooth functioning. So like there is a spinal cord, the sensory motor area is involved, the pre-supplementary motor cortex is involved, the ACC is involved, the cerebellum is involved, the visual pathways are involved, and the gait. For the gait, we have to assess the posture, the length, speed, and the rhythm of the steps, how the symmetry is there, the steadiness, the arm swings, the turn, and test with the normal gait. There's a phenomena which is called paradoxical kinesia in the patients of Parkinson's, where they have a freezing of the gait, and we give them the transverse lines like on the on the floor. Then they're easy walk. For them, it is easy to walk then. And we also should assess for the primitive reflexes like Landau's placing, parachute, and suck, grasp, and Moro's reflex. Now I'll ask Susmita to take over.
So, after the long discussion of Dr. Divya, we the psychiatrists may be thinking why we're doing all this thing, why to waste our time by doing all this tedious examination. Rather, we can go for more detailed history and we can build some rapport with the patient in this meantime. So, coming to it, like how it's important. See, we know that brain has all 7 function, and it when psychiatric patients are coming to us, the patient will not only come with the behavioral disturbance, some other component will be there. And if we are missing them, then some diagnosis or these things can be missed. And another thing is, while we are doing this meticulous examination, then we can also correlate things like this patient is having this sensory system, then this. So correlation become easier for this patient, and we can treat more efficiently. Now, coming to the cranial nerve. So, uh, what more to tell about that? Cranial nerve itself originates from the brain. So, cranial nerves gives the localizing sign for the brain dysfunction. Cranial nerves, like if I start like listing the thing that first cranial nerve in which psychiatric disorder, it will be very big list, and it's not possible in this short duration of time. But I'll give some hints so that we can think logically and then find out of our own. Like for first nerve, the olfactory nerve, we know anosmia is a sign. It is also called frontal lobe sign, previously called anosmia. Our patient presents with anosmia, and anosmia sometimes, or like anosmia or parasmones, there is difficulty in smell sensation. And from this we can also differentiate between the type of neurodegenerative disorder. Like patient with parkinsonism has more chance with the more chance of presentation, initially presenting with the anosmia. Patient with Lewy body dementia has more, like synucleopathies have more predisposition to have anosmia. Then coming to the second nerve, optic nerve, we know that organic lesion, and that can lead to visual hallucination, and this can be involved in multiple sclerosis. Then second, third, fourth, sixth, this gives us the status of the midbrain. So we can get the status of the midbrain by checking them. So any condition of midbrain may reflect here. Then coming to the seventh nerve, we all know that the CVA, the affection, all this thing. Then coming to the 9, 10, 11, 12 nerve, we know that how we can this can present the symptom of brain, like patient with having EPS, extrapyramidal symptoms. We have given antipsychotic, and patient is developing that. We find that there is swallowing reflex, gag reflex. These are affected. How? Because they actually they originate from the brain, and then they relate to the other centers. So they are reflecting the abnormality of the basal ganglia here. So that's why cranial nerve is important. Now coming to the sensory function. So what is sensory function? Basically, it's not only the sensation proper, sensation component. It has three components in it: sensation proper, emotional component, and cognitive component. So how we can navigate? See, we know that there is psychiatric patients are having the sensory integration problem, and along with sensory integration problem, but at integrate level it's very difficult to find. But if we start examining, we'll find that there is some patients are more sensitive to pain, then patients are less sensitive to it, and someone having differentiate sensation. Like if I there only I mentioned four disorder, but if I start talking about them, almost everything will take into this place. Like fibromyalgia, we know the sensory component, that pain sensation, they're having tenderness in multiple points. They're having the cognitive symptoms like cognitive fogging, emotional disturbances is here there. In somatoform disorder, especially somatoform pain disorder, it is established that pain threshold is lower in these patients. Then coming to the autism spectrum disorder, in autistic child, we found that they are very sensitive to some kind of stimuli, some sensation, and in some stimuli they are not responding at all, or they don't bother at all. Like some child are present with that, they don't feel pain sensation as a painful stimuli. They feel it some other stimuli. So these are the condition we can relate with that. Now coming to the motor system. motor system, Dr. Divya already explained how to examine and all that part. So why motor system is important? Okay, so in motor system, while seeing the power of muscle, why it's important? Like there are, we in psychiatry we deal with lot of mitochondrial disorder, and in mitochondrial disorder brain and muscle almost get involved equal manner. When while examining the power, while examining the bulk of the muscle, we are seeing more of fatty pattern than that fibrous deposition. So that will give us hint about the, like that patient may have some underlying mitochondrial disorder. So we investigate for CPK ammonia level accordingly, and the treatment plan will totally change. Next slide.
It's there.
Then coming to the reflexes. So what is the reflexes? What this reflexes deflect? It actually indicates the state of brain, the brain activity and the autonomic activity. So we can simply say that autonomic hyperactivity, brain hyperactivity will lead to hyperreflexia. And if any the descending lesion, cerebellar descending pattern, you will get the decreased reflex. So accordingly, the superficial reflex and deep tendon reflex will replicate like that only. Like I'll just name few example. Like superficial reflex usually helps in like determining the dermatomal level in case of spinal cord disease like ankylosing spondylitis, TB, syringomyelia, then ALS, multiple sclerosis. These are there. So I'm just naming few of them so that we can start thinking about that and about every aspect, and then we can correlate it. Coming to the deep tendon reflex, the one fun fact about deep tendon reflex that we can stage the level of the stage, the psychosis, in which stage patient are by simply seeing the, like we can have an idea. It's not definite that we'll see, but we can have the idea. Like as I described earlier, what reflexes they reflect. Okay, so patient who is very violent, aggressive, having severe hallucination, they will have brisk DTR. And patient is having normal DTR, so we can assume that patient is probably non-violent. So that we can think that his brain activity and autonomic hyperactivity is not that much high. In case of sluggish DTR, patient will have decreased like decreased psychomotor activity, psychomotor retardation. These things will be there. So now coming to the gait. So why gait is important? A patient of, like we diagnose patient of psychosis is coming to our OPD or department, and then we see some gait abnormality. What does it implicate? That along psychosis is just manifestation of brain. It's a brain symptom. So patient is having with gait abnormality. So what does it indicate? There is some other thing we have to dig in. So, like in case of patient presenting as a feature like ATPD, and we know that autoimmune encephalitis comes to ADD when there is acute and sudden deterioration of the symptoms. So in that we will find gait abnormalities, and along with that motor involvement will be there. And usually psychiatric symptoms present in some variant of autoimmune encephalitis. And first 1 to 2 week patient will come with the psychiatric symptoms only, and some other minute neurological sign that we will easily like ignore, or we won't see that once we don't make the habit of seeing all the seeing or doing all the neurological examination. Then cerebellar involvement is very important. Now we recognize cerebellum. It's the roles are evolving more than a motor function. It has it's like another cerebral cortex. So we are getting inside of that. So cerebellar involvement can be, if there will be gait abnormality, and disease of basal ganglia, as all we know that basal ganglia coordinates our fine motor movement. So any disease of basal ganglia will affect the gait. So this is the, like, I have whatever the examination point we see, we do, I just tried to put some insight into all of the points. Okay, like some I mentioned some important disorder, but it's very incomplete here because we'll get lot of list, and once we started seeing it, it will make difference to our understanding and make difference in our treatment plan, and obviously our better understanding. Thank you.
Bhaskar, are you there? I think two young ladies are done with their presentations as I see it. Dr. Divya, is it?
Yes, sir. We have the
You
presentation.
have done already.
Yes,
Yeah.
sir.
Bhaskar, please.
So my job is to not add anything.
Yeah.
I am
So,
here if they need my help in answering. Otherwise, I am here to listen to them and just being proud.
uh, what I feel, shall I start then? Because there is a question in the box before we, Nachkita has posted a question. Before we go to the questions, I urge others to ask the questions. And Dr. Bhaskar is there to moderate or answer your questions as well.
Hmm.
But what I could understand, Bhaskar knows that
Hmm.
I am working in a general psychiatry hospital unit in a medical
Hmm.
college. So I tell my residents who are doing post graduation in the department that particularly once you are working in a general hospital, whether in the casualty or in the OPD, where you have predominantly referrals from the other specialties, and some of the patients coming up their own to our OPD, I tell them if the diagnosis is absolutely clear of any psychiatric disorder, it's fine. But if you have an iota of doubt, even 0.001% of doubt that it doesn't seem to be a purely psychiatric issue, please and please rule out organicity. And as these two young ladies have beautifully portrayed the importance of, especially we can see the neurological examination, starting from the consciousness, then talking about the cranial nerves, talking about the reflexes, then sensory the component and memory, everything they have beautifully done it. I think Bhaskar, if you could have more comments, we would like to have more comments from
Hmm.
yourself before I take
No,
questions
I
from
would
the.
be I would be partial in my comment.
Yeah.
I train them. I teach them.
Okay.
So I should not be commenting
Okay.
because I would be highly biased.
Okay, so there is a question from Dr. Nachiketa Desai, one of our own psychiatrists, our friends. Are these pointers to be assessed in addition to usual mental status examination or replaces current assessment approach? I hope you got the point of Dr. Nachiketa is asking. Dr. Nachiketa, you can ask yourself.
I think, like what we have talked recently about the psychomotor, you just talk about the psychomotor, the whole motor examination we are doing rather in detail. The speech we are assessing, the language, each and every part is we are assessing. And not to say that, but like what you assess in thought and perception is always a complaint which patient has mentioned. And we never get more than that. We have a we have a delusion. And so it does not make much difference, even if we are getting it, like you can include the thought and perception. Only a single question is if there any problem is there, because the other part, this whole explanation has covered it. I think so. Any other like Bhaskar sir can give a better feedback in this regard.
Hmm. এই তো সবাই দেখি দেখি গেছে।
Dr.
Bhaskar,
Bhaskar, please answer the question.
yeah.
We can't hear you, Dr. Bhaskar.
Yeah, Dr. Jagjot, please go ahead. Welcome
Hello,
and
sir. Good evening.
yeah, please go ahead if you have a question.
Yeah, the question is already.
You're not audible.
You are muted. Muted.
Jagjot, unmute.
Jagjot, unmute, please.
Okay, so I
Jagjot,
thought I
unmute
was
yourself.
Yeah, Dr. Bhaskar, you've been put up. There's a question being put up to you. Why haven't you replied until now? Is my first question. Second, please speak in Hindi. We don't understand Bengali.
I was actually talking to someone else. Oh, yes. So what?
So, yeah, in psychosis, the deep tendon reflexes. And what are your expert comments on gait? So let's say the patient enters the OPD. What can be, what can we get to know about the diagnosis from just the gait of the patient, from a psychiatrist perspective?
Number one, when a patient enters, the gate says a lot. Whether the patient is favoring one side or not, that is one thing. Number two, if the gate is coordinated or not. Number three, if the gate is fast or slow. All three are controlled by number one, motor system, number two, proprioception and balance system, and number three, the autonomic nervous system. So just by seeing the gate, we can understand these things.
Right. So what if the patient is swaying to one side? What should we rule out?
What if the patient is swaying to one side? Then we have to see that number one, whether there is any weakness of one side or not. Number two, we have to see whether the cerebral lobes of contralateral side are working well or not, and things like that.
And which investigations do you suggest to find out what is the cause?
Mostly, if the system can be assessed enough from clinical examination, nothing else to be done. If clinical examination says there is autonomic hyperactivity, we don't need to do a costly MRI to judge that. If we already find the level of lesion, then we don't need to do a costly MRI or other thing. If only we are not sure, if only we are not able to find the level of lesion, then we can do MRI or other thing. Our examination should be such a way that tests are accessories rather than the main thing.
Okay, in which case would you prefer CT rather than an MRI?
Only if I am thinking that there is basically history of head injury, history of blunt trauma, and there might be acute bleeding. Otherwise, everywhere in case of psychiatry, MRI is much, much superior.
Okay.
But the question is, why I am answering the question?
I don't know. The question was put to you. I just forwarded
You are the senior most, you are their mentor, so you are supposed to answer questions on their
No, they are going to be answering first. If they are not doing it,
I did.
I am
You were
there.
with some conversation in Bengali, so we thought you are answering our questions, but you
No,
are
no,
talking
no, no, no.
somebody else. You are
No,
talking to
no.
somebody else.
Okay.
Anyways, we have another question asked by Dr. Sharik. He has heard that we can judge degree of psychosis by deep tendon reflex. Can you please elaborate on the same? The degree of psychosis by deep tendon reflexes.
It's more about the symptoms, like rather than the degree of psychosis. Like the increased DTR is seen more commonly in the patients who are agitated, or there is like positive symptoms, and the DTR is normal in the patient who has a negative symptom, and it's decreased in case of like negative symptoms. So it's rather than like saying degree, it is like more about the different profiling of the symptoms.
Okay. Aleem, are you still there? Dr.
Yes,
Alim,
boss,
sir.
I'm there.
Yeah, please, sir, ask your question. You
I'm
have
there,
put
sir.
it. Yeah, please.
Yeah, I was putting like a good student. So,
That's why I told you ask like a good student.
maybe actually I have missed a part of the presentation, so I may be repetitive. So, uh, are we talking about the so-called soft neurological signs to detect? Suppose,
So there
is there something like soft neurological signs? Are we talking about them? And a note also on minor physical anomalies. So,
so,
how is this important in our examination?
so we
Sir,
Susmita is here, I think so.
soft neurological signs basically they are the signs that tell us about the subtle deficits in the sensory process and motor in coordination. Until now, like lots of studies have been done, like what soft neurological signs are available in schizophrenia, what in case of bipolar disorder, and there are also studies they have found that similar kind of symptoms, soft neurological signs are present in schizophrenia and bipolar disorder patient. So this was also another indirect in the evidence that kind of reflecting the BSNP studies. So, regarding soft neurological diagnostic validity, I'll say no, that this soft neurological signs are present, so we'll think of that. These are of more of value, like, but this has been clear till now. The there are lots of research in schizophrenia, bipolar disorder, and other. But it has been clear that the number of soft neurological signs that are present in patients of psychiatry are more than that of general population, and it is also present in the FDR, first degree relative, and even these are like intermediate phenotype. Even after these are present after the disease is cured, or like even before starting. Hello.
Yeah, please go ahead. You are audible. Please go ahead.
Okay. So even naive antipsychotic, naive patients, these are also in. And regarding scale, sir, I would like to what I have just put the slides of many scale for neurological soft sign. This is the first one that has been put forward. Actually, Dr. He observed that child with hyperactivity having some uh, some abnormalities in their appearance, and there are soft signs are there. So he actually planned this for his children, and then gradually it was adapted, and there are like multiple versions. There are changes.
I think there is some issue with Dr. Susmita with her audio, with her internet.
Okay.
Yeah.
Sorry,
Bhaskar,
sir.
Bhaskar,
There
are
is
you
some
there?
interruption.
Bhaskar, are you there? Yeah,
Uh,
Susmita is back. Yeah, we're in between, not able to hear you.
so,
Please go ahead.
sir, there was interruption in Wi-Fi. Am I audible now?
Yeah, but it's breaking. Anyways, you please continue. If it is not comprehensible, then we can tell you to stop. We'll move on to next question. You can continue if you want to.
Okay. So, May's version, there was two division in that: minor malformation and phylogenetic variants. Then rather criticism has been there, like they didn't put forward like only phylogenetic variants, no, nothing like there is no difference between genetics, epigenetics. So how will, so there are different version of that, but mostly the basic idea is brain is ectodermal origin. So it, whatever this neurological soft sign and the minor physical anomaly, they are actually presenting the signs of disturbed morphogenesis that has been occurred in a subtle level, so that in other areas we are seeing subtle signs, not definitive signs. So and the main pathology is the same, like whatever at the ectodermal origin, you will go and see if there is any abnormalities there or not. No, sir, no diagnostic value. Like,
Aleem, I think things are a bit clear to you as a good student. Or
What actually the voice was cracking, so I could not make full think of it. So, should we be keenly observant like Sherlock Holmes, observing the patient's face, the facial asymmetry, any abnormal movements, how is the gait, how is the voice? So all these things, I think we need to have these parameters in mind whenever the patient is entering the OPD. So whenever the patient is visible to you in your CCTV camera or your in your OPD, you should start observing. If you have read about these so-called soft signs, or just as we discussed, these minor physical anomalies or motor and sensory examination, so that is a thing of practice. If you start practicing, you will start finding these signs in your patients. So, and then again, if you are finding these signs, so it may not be of immediate diagnostic significance as per the current system, but still you are able to get some detail about the patient. So I think that is all I wanted to say. And now I'd like to hear what the other people want to tell us.
Bhaskar, are you there? We don't want you to be a mute spectator.
Yes, I am there, but I am actually seeing patients as well as I am present in the webinar. So I am in between keeping myself muted. Otherwise, you would hear a lot of Bengali word and you would get confused.
Okay. So can you add to it, or I will move on to the next question?
Please repeat the question.
It was about the soft neurological signs, how important they are.
Bhaskar, the question,
Yes.
the question is, suppose a patient enters, so I have to observe his facial asymmetry, his walk, how he sits, the movement.
Yes,
And
yes.
what are those points that one should know that you have to observe the patient across these points at least? So the important points that we should keep in mind, so that these soft signs, minor physical anomalies are known to us, may not help in immediate diagnosis, but will help you prognosticate and plan your treatment.
It
So your
would
comments.
actually it would also help in diagnosis as well as prognosis as well as therapeutic. If you remember Nonan's or May's scale, or if you remember Waldorf scale and apply to each of the patient, you would find that the higher the scale score, the higher the chances of normal treatment not working, number one. The higher the scale score, the higher is the chances of needing a lot of complicated polypharmacological regime. The higher the scale score, the higher is the chance of other complication. Means, let's say, development of metabolic syndrome, development of other abnormalities, other systemic complications, they would be there. So it is both for prognostic as well as diagnostic purpose as well as therapeutic purpose.
So does it represent pan system damage?
Yes,
Baseline damage, pan system baseline
it
damage.
always represent pan system damage. It always represents, because minor physical anomalies are not limited to one single cell. They represent multiple areas of heat within an organism. So they are pan systemic damage. If you ever apply this minor physical elementary cell scale to other non-communicable diseases, let's say diabetes, let's say hypertension, you would find the same thing. The higher the scale score, the higher the problem. In fact, this is actually a beautiful research idea if anyone wants to do it. Application of minor physical anomaly scale in cancer or in various non-communicable disorder and finding out the prognostic implication.
Okay.
Thank you. Thank you very much.
Sir, I want to
Yeah. Please go ahead.
Sir, like while seeing the patient, I have developed like some I clap them so that I can see them within 2 to 3 minutes. So, like for Mehe scale and wardrobe scale, I have clapped them. Like it's easy to go from. Hello.
Yeah, please go ahead.
So I clap them so that we can see it. It's not possible to do all the scale wise thing. So I try to see from head to toe. Like in head to toe, in wardrobe scale, it is there like only ear and ear deformity and circumference of the ear, and in case of neurological soft sign, along with that, we have to see the forehead, the occiput, and then in head, then eye, epicanthus, all this thing. And we have to examine the scalp along with the minor what word of scale is saying. Then in case of eyes also, word of scale is the minimal version of that. Like what I do, like if we club this two, then it's very easy to see. Just we have to remember the things once we start from head to toe, it's easy to do. We won't get the score, but we'll get the idea, like how much anomaly this patient is having.
Yes, that's the good idea because that's how I also started doing.
Okay, so there is a question by Surabhi Chatterjee. Can superficial reflexes also help apart from DTR, apart from deep tender reflexes?
Yes, same mechanism.
Same mechanism. Okay. Then another question is from Dr. Pramod. I think sir is there.
Yeah.
Yeah, please, sir.
Am I
If you,
audible?
yeah, you're audible, sir. Please go ahead.
Hey, I wanted to know whether neuromodulation, in context of neuromodulation and artificial intelligence coming into practice, what the speakers have to say about it. That the younger generation has to know about all these newer techniques and dimensions of neuropsychiatry and assessment of the patients, or we will have to depend only on the clinical examination in future.
AI is an important part, I believe. But for that, we first have to know the hypothesis which we are proposing. So, like what I'm saying, the computational psychiatry, the AI, they all are very important part. But for that, we have to know what hypothesis we are proposing and how we are going to test it. Because what happens usually, these research is being done by not clinical people. They are being done by the computers scientists, means the people who have the BTech degree and all, and the psychologist and all. So even if we want to understand the networks and hubs, we easily get that from the models, actually, the brain models which are being coming up with the help of all these computational things. But if we have to learn that, because if we will not understand, we will keep on sticking to the old things and will not know how much science has progressed in last few years. So that's what I believe.
Sir, you unmute. You're muted, sir.
Am I audible?
Yes, sir, please.
Anything about machine learning into the practice?
Machine learning, to be very honest, when I have done the course, I think I was the only psychiatrist and two other people who were MBBS there. Most of the people were data scientists and the psychologist people were there, or the people who were from the MSc or BSc background. So it has a role. That's what I'm saying. They propose the models from the fMRI data or the EEG data. But to understand the data, to understand the clinical relevance, we people have to be there to tell what is actually like you are using as a feature and what all it can tell us in future. Because what they tell is like what is their interpretation of brain, but we are seeing in clinics, so we have to give inputs regarding it, and we should actually actively pursue it.
Thank you. Thank you.
Dr. Jyoti Shetty, are you there?
Sorry. Yes.
Yeah, please go
Actually,
ahead.
I think I probably missed some part of that sensory examination because I just saw the right side of the slide. It had I think there was fibromyalgia, somatoform pain, and borderline personality, if I'm not mistaken. So, what exactly in the sensory examination should be picked up? Because in a busy OPD, it may be difficult to do, as everyone has said, to do a complete thorough physical examination.
Ma'am, what we can do is like we examination in whoever doing the examination, we do like everything comes sequentially according to the history, according to the chief complaint. We formulate something that there may be problem in that area, we focus on that area more, and then in examination also, like likewise, if we start asking the right question to the patient regarding we usually neglect the thing, like our patient come with like they will be saying we are having burning sensation, having this vertigo, all these things, and some unusual sensation, and we discard easily by saying this is some somatic complaint, some this kind of thing, functional things and all. So that's where patient usually tells us, and like taking the history, we have to ask that if there is any abnormal, like in sensation purpose, what the standard question, and if it is coming out like patient is having some, then we will go it thoroughly. Otherwise we can like it's I understand it's even it's like it's very difficult to the vibration signs, then fine touch, crude touch. These are difficult to do in OPD schedulers while see the patient. But we have complaints like that, and we are like hinting, like we are thinking something like some sensory system involvement is prominent. Like in case of long tract sign, we usually miss this and all this thing. So I think it's more about like what we see the patient and understand about it. But our focus here is to like we usually miss that thing. So uh, we try to point out like what can be possibilities in every system so that we don't miss them. That was the idea. But yeah, ma'am, it's not possible to do all this thing like as theoretically like all procedures.
Yes. Yeah, because why I asked is because just today I had a middle-aged lady postmenopausal with somatoform pain, but it was a very specific genitourinary pain and very significant hypersensitivity. She could localize, but there was nothing on examination. I mean, she was seen obviously by urologists, gynecologists, and all. So I was really wondering, like, as to what exactly, and of course, she's had a history of many years with vertigo that subsided. So she has been obviously progressing with different symptomatology, obsessive compulsive traits, personality underlying. But my interest in that was because of that. So then, if it's a sensory examination, what exactly could be pinpointed? Because fibromyalgia, it would be all over. But when it is a very specific area, is there something that we could do in terms of testing? That was why I asked this question actually. Thank you. Maybe
Ma'am,
Bhaskar could ask answer.
answer this partially.
Bhaskar, are you there? Yeah, Bhaskar has
Yes,
come in.
I am there. Finally ended clinic. Okay.
Okay.
Hmm.
Did
The
you, did
thing
you,
is,
yeah.
I heard the question of Jyoti ma'am. The thing is, ma'am, this is actually a spectrum. This is there is no textbook answer or no research academic answer to these questions yet. But I can share my experience. I have similar patients who has menias, who has typical dyspareunia, who has pruritus ani, who has pruritus valvi, as well as they have a lot of various systemic symptoms who are very specific, which is very specific. And ultimately, I have seen many of them progress to frank autoimmune disease. So there can be a till cannot say that.
Okay.
I'm sorry, Bhaskar, I lost your last bit. Can be a prodrome. You said something else.
It is many a time these patients start with these syndromes, but finally they progress to some or the other manifested autoimmune syndrome. And in my area's patient, the most prominent autoimmune syndrome that is associated with it is Sjogren's syndrome. But I don't know what would
Okay.
be the autoimmune syndrome in your sets of patients. But
Yes.
mostly Sjogren present with this kind of non-specific symptoms followed by specific others.
Okay. Thank you. Thanks a lot. Thanks a lot.
Thank you, Bhaskar, and thank you, Divya, Dr. Susmita. I think we had a wonderful. If
I have
nobody else has a question, I think it's time to wrap up. You wanted to say something, Dr. Divya, before we conclude?
logical examination from the Merck manual.
Yeah.
And so we have missed a question about saccades. So I wanted to tell because like this, it is like governed by a lot of memory guided and visually guided. So there are DLPFCs and all are involved. So any dysfunction actually, like we can pick it up on the frontal examination and all those symptomatology. And also like there is studies which says the gaze behavior and all is impaired in the social anxiety disorder along with depression and autism. Even in schizophrenia, there's anti-saccades movements are like, lagging behind. So yeah, it is important actually.
And
Thank
also, like I want to add, like in case of Parkinsonism disease, initially like this bradykinesia and all this thing, eye saccades, like there is slow in eye saccades. These are one of the earliest sign to pick up like Parkinsonism disease, Parkinson's disease.
Especially progressive supranuclear
Any Parkinsonism, the eye movement are the fast to go. Any Parkinsonism. Yes, different Parkinsonism would have different eye movement abnormality. For supranuclear palsy, it is down gaze. For usual IPD, it is horizontal, but it would have
I think. Thank you very much, Dr. Bhaskar. Thank you, Dr. Divya, Dr. Susmita Sarkar, and I think Dr. Avinash is here. Dr. Avinash Desousa, you have been
Mm,
all through. I think he has signed out, I suppose,
mm.
on there with us. Anyways, thank you all for wonderful interaction. It was beautifully presented by both ladies, and we have actually decided that we can field younger players in the field so that we learn more from them. They have additional degrees than us. We are an older lot, just trying to
Yes.
catch up with our patient load, and younger people have many more degrees than we have, and we are always excited to learn from you all. And it is I'm highly thankful to the speakers, especially, and Bhaskar Mukherjee, Dr. Avinash D'Souza, our president of IABP, Dr. Sunil Mittal, Vice President Avinash D'Souza, and Pramod Kumar, and Dr. Rukshida Saida, whose brainchild is this IABT CME series, Alim Siddiqui, who is our editor, and Nishant Goel from CIP Ranchi, who was our treasurer. Sagar Karya is one of the very important members of this family. And we'll continue with this series, and we'll come next month again on the first Friday with this. And thank you all delegates who have been there all the time and have been asking questions, making it an interactive session. And the lovely lady behind the scenes is Amita, who is from Medisquare, who has helped us during this. Amita, thank you so much. And Torrent Pharma for supporting this initiative. Thank you all. Good night and see you next time.
Thank you.